Welcome, everybody, to a Friday installment of our Airway Circle Thursday Night Live webinar series. If you are a member, you are able to watch our Friday events live. If you are not a member, please consider joining us at www.airwaycircle.com/membership. And we hope you enjoy this presentation. I am very pleased to be able to introduce Dr. Eduardo Javier Correa, an otorhinolaryngologist from Argentina, who's currently working in Spain, if I'm not mistaken. He has a degree in sleep medicine from Austral University in Argentina and has been specializing in the field of sleep apnea for almost 15 years. Dr. Correa is certified by the European Board of ORL-HNS head and neck surgery in otolaryngology and by the Spanish Sleep Society as an expert in sleep medicine. His primary research focus is myofunctional therapy in sleep apnea, and the topic of today's talk will be on myofunctional therapy in obstructive sleep apnea. So I think that will appeal to a lot of our audience. So welcome. We are so appreciative that you've been able to join us. Thank you so much. And you can go ahead and add to if I missed anything and share your slide. The floor is yours.
Thank you, Anne, for the presentation. You didn't miss anything at all. So now, thank you very much for the presentation. And of course, I want to thank you for inviting me to be part of the Airway Circle. I'm glad to be here.
You're welcome. We're happy to have you.
Yes. If you want, we can start sharing the screen.
Yes, please go ahead.
You see my slider?
Yes, looks good. Perfect.
Well, as I told you, thank you for having me here. I will tell you about myofunctional therapy from an ENT perspective of what we are doing right now here in Spain. And our lecture, let me try it. It's not running, sorry. There you go.
There you go.
We will go through mainly 4 key points. First, why is that we use myofunctional therapy, and what do you consider it for the treatment of sleep apnea? Then we will review some of the literature available and try to view some of the demonstrated benefits of the myofunctional therapy. I will show you our clinical evaluation from our point of view, but my intention is to make it in a way that it can be applicable for your practice as well, so you can use it indeed. And then I will show you how we are using myofunctional therapy in our practice nowadays. We know that from more than 10 years ago, Ecker defined the phenotypes for sleep apnea. We know about the lower arousal threshold, the Havelock gain, and the most famous one, the anatomical obstruction. But today we'll focus in this one, that is the muscular hypotonia, which means the lack of effectiveness of the upper airway muscles to maintain its patency, of course. And we have to keep in mind that we are talking about functionality, and that's the most important thing. There are colleagues that still nowadays consider the tongue just a muscular structure for eating and speaking, and that's all. But we have to consider that the tongue and the orofacial muscles are really a complex system, and we should understand that with different features such as strength and endurance, mobility and praxia, we call it, of course, sensorial, the tongue is involved in the taste perception, and one of my favorite, stereognosis, that is the ability to identify structures and shapes just through the sense of touch with the tongue. And of course, these are involved in more complex stomatognatic functions such as feeding, swallowing, breathing, etc. So we must understand that it's not so simple. We have to consider as a complex system. And what is myofunctional therapy? Mostly you already know about this, but as a brief introduction, we could say that these are a set of orofacial exercises aiming to orofacial structures to improve the muscle strength and endurance, and of course to enhance the responsiveness and coordinated recruitment of these muscle fibers. Of course, myofunctional therapy will help with praxia and stereognosis and will enhance different functions such as swallowing, breathing, etc. by providing a more stable upper airway. So let's get a little bit with the literature. Does it play any clinical benefit? What does literature say about this? I brought just a few examples, but this one right here is, for me, one of the most classic ones, and it's actually a trigger for the research in the field. In 2009, Guimarães performed this clinical trial with 31 patients that were randomized into exercises group for orofacial structures and sham therapy. And after a 3-month period, they showed that the intervention group presented with reducing snoring, an improvement of the daytime sleepiness, and also a decreased apnea-hypopnea index. Then, several years later, Vanessa Yeto published this in 2015, also a randomized clinical trial with 39 patients that were divided into myofunctional therapy or a set of respiratory exercises, but not aimed to myofunctional therapy, plus nasal dilator strips. After 3 months, the intervention group presented with a really strict improvement in the snoring index. This other one is really important from Maria Pia Vila, 2017. They working with children and collected 45 patients that were also randomized into myofunctional therapy or control group without any intervention. The mean age was about 7 years old. They addressed several things. On the result, they show that the intervention group presented with an improvement of the lip hypotonia, a shift from oral breathing to a nasal breathing pattern, and also an improvement in the tongue position. The EOP that you see here is actually, the EOP values are the strength and endurance of the tongue, but also increasing in these patients, as well as the oxygen saturation index. This last one, I will not get into detail right now because I will get back to this paper later, but Dr. O'Connor collected 28 patients and randomized into myofunctional therapy or control, no intervention at all. Also showing an improvement in the Epworth scale. That means an improvement in the daytime sleepiness, reduction in AHI, and also increased IOP values. Of course, we always like better the clinical trials, but there are not so many, so we have to grab on reviews. This one is a classic one from Macario Camacho group from 2015. They included 9 studies with 120 patients. They also concluded that the myofunctional therapy improves daytime sleepiness, snoring, AHI, etc. But there are 2 important things or results with this review. First, the AHI was reduced at half in adults and in 62% in children. But one thing that is really important of this manuscript, it showed that patients under myofunctional therapy presented with an increased time of use of CPAP therapy. And that's really important, because we know that until today, the first-line treatment for sleep apnea in adults is CPAP. And myofunctional therapy can improve and enhance the adherence of this therapy. Also, De Felicio published another review, also showing improvement in sleep quality, daytime sleepiness, and the AHI. And this is from our group. Actually, we were working with ankyloglossia, but we had to perform a systematic review, and we also included 7 studies, and most of the results were the same: improvement in daytime sleepiness, snoring, the AHI, and the saturation index. So we have several manuscripts and publications that support, that back up the use of myofunctional therapy. But we have to write and publish. And what is that I tell you this? Because sometimes we work and we don't publish our result. And the consequence is this one. a few years before, we review all the official guidelines for the sleep societies around the world, or recognizes well-established sleep societies. And if you see, none of them recommending any functional evaluation of sleep apnea patients. Only one of those that I will show you by the end of the lecture. But it's important because in the sleep apnea field, myofunctional therapy still hasn't had this place because we are not publishing results. So we have to write and show all the others what are our results with myofunctional therapy. Let's move to the clinical evaluation. As I told you, we as ENT are privileged. We have received lots of training, and also we have the proper instrumentation for evaluating the upper airway. And as you may see, there are a lot of things to take care of. But today I want to focus on the exam in a way that it can be useful for your practice. I will start with the nose. We know that nasal obstruction impairs sleep quality and also affects increasing the daytime sleepiness and increases snoring. But there is something important, that the main complaint of those patients that are reluctant to use CPAP therapy are related to the mask. And the main complaint are the nasal symptoms. So we must, if we are working with sleep apnea patient, I think that everyone that is involved in the treatment of these patients should be able to identify different nasal diseases. Okay? And what about the surgery? Because your patient will ask you about the surgery. We know that any surgical procedures on the nose can benefit our patient by improving subjective symptoms, sleep quality, daytime sleepiness, snoring, etc., but has almost no impact on the objective parameter, as the AHI, saturation index, etc. The main use of nasal surgery in sleep apnea is related to an increased adherence of CPAP therapy. That is the main prescription of nasal therapy. How to diagnose it? I will show you in the next slide that it's actually really easy to identify a severe nasal obstruction by the use of just a simple frontal light examination. And we always have to keep in mind something that is really important. Any nasal obstruction will lead to a compensatory oral breathing, and we have to keep that in mind now for patients. So I prepared this video to show you an anterior rhinoscopy. This is what we can perform without the use of an endoscope in our practice. Okay. What you will see here is a nasal speculum. You can see it twice. So the main thing is we open the nostril and we identify different structures. First, we have to take a look at the nasal mucosa, the characteristics, the color. Is it red? Is it pale white? Does it have our patient any rhinorrhea? We can identify with this. And also, you can identify any swollen turbinates or any septal deviation. And of course, if patient presents with nasal polyps, you will see it anyway. So this is the first thing. But what happens if you don't have at your hand a nasal speculum? Actually, you could use any speculum you can grab in your hand. The main thing is to open your nostril, open the nostril, and take a look at this. And what if you don't have anything like this? Sorry, if you don't have any speculum at all, there is no problem. I will show you, you can use just your thumb and open the nostril of your patient, and you can easily identify the nasal septum, the turbinates, and trust me, you can identify septal deviation, nasal polyps, signs of allergic rhinitis like rhinorrhea and a pale white mucosa. You can identify swollen turbinates. So it's important for you to understand this, and I encourage you to try to apply this to your practice. What do we look for in the oral cavity and oropharynx? First, we try to make a brief assessment from a dental perspective. Of course, in the same way that I will not ask anybody that is not ENT to perform a precise diagnosis on the nose. I will not ask myself to perform a precise delta diagnosis. But we always look at facial profile, dental occlusion, and any signs of malocclusion like overbite, overshed, etc. And what is it that we use it for? First, it can provide such useful information of the upper airway. Let's say, for instance, we have a patient with a retrognathia. We know that, let me change this. We know that this patient may present maybe with a narrow upper airway. But also, all of this can help us to identify if any therapeutic approach could be recommended or discarded for our patients. Let's say the same patient is prognathic, he doesn't want to use the CPAP therapy, but has with this. We know that after CPAP therapy, we can recommend oral appliances to our patients that have really good results. But those patients maybe could be limited in the prescription of oral appliances. So it's not for us to become dentists, but to have an idea of what they can offer to deal with our patients' expectations in health. Signs of oral breathing. We see this every day. This is a classic patient with a banded posture. We see the retrognathia, the mouth almost open, or if not, a lip hypotonia, the tired eyes. And of course, we have to take a look at the hard palate, and because we know that a narrow palate of the higher palate are all signs of a chronic oral breathing. So we have to take a good look at the nose, at the breathing pattern of our patients. Following with the oral cavity, what else can we look at? These are the Mallampati score and the Freeman-Tone position score. Just as a reminder, the Mallampati score was not designed for the sleep apnea, but for anesthesia. It serves to help a prediction of a difficult upper airway in orotracheal intubation. We use it with the Freeman-Tone position, but as this Spanish statement, it said both of them have really a positive but a small correlation with the presence and severity of sleep apnea. But we use it mostly because it can help us identify any patient that maybe with some specific surgical procedure could be benefit. And of course, we always take a look at the tonsils of our patient. These are 4 grades we can recognize. We know that the size and the shape and the characteristics of the soft palate, the uvula, and the tonsils do not correlate with the presence and severity of a sleep apnea, of course. But as a reminder, the first-line treatment for pediatric sleep apnea is the adenotonsillectomy. So we always have to take a look at it. And from a few years ago, we started recommending tonsillectomy also for adult obese patients, because we know that tonsillectomy maybe could slightly reduce the AHI, but it could help our patient to increase the adherence to CPAP therapy. And now, moving forward, we go about talking about the ankylosing. That's one of our line of research nowadays with Dr. Carlos O'Connor. This drawing is from one of our publications. In a normal situation, the tongue is usually in contact with the hard palate just behind the incisors. Okay, what happens in a patient with ankylosing? As the tongue is tied to the floor of the mouth, it cannot reach the hard palate, and it takes this outward position, moving slowly backwards to the oropharynx. And several years ago, Guillaume Mignot also stated the role of ankylosing in the craniofacial development, as well as contribution in the development of sleep apnea as well. How is it recognized, ankylosing? Typical situations are newborns and babies with feeding difficulties, or maybe a few years later, at 4, 5, or 6 years old, kids with speech difficulties. But we know, of course, that ankylosing could be asymptomatic. So it's important for us to screen this condition, because ankylosing will lead to oral breathing as well. and contribute to oromyofacial dysfunction and sleep apnea. There are several publications. Just to explain this in a simple way, in a normal situation, the tongue is in contact with the hard palate, and it serves as a stimulus for the growing of that hard palate. Okay? In patients with ankyloglossia, with a short lingual frenulum, it conditions a maxillary deficiency at the presence of a small upper airway, favoring a collapse during sleep and the development of different sleep breathing disorders. Different authors have also shown that patients with ankyloglossia present with an increased incidence of palatal and maxillomandibular disorders. And they have also shown that ankyloglossia is an independent risk factor for sleep apnea. Of course, there are more publications about a modified craniofacial growth in patients with ankyloglossia. That is why it's important for us to take a look at it. And how can you perform an evaluation of the frenulum in your office? There are several scales, Cotton, Ruffole, Hasselbacher, etc. As you may see, there are different scales, different ways of measuring. This is a quintile assessment tool that you can buy online. And I will show you what we use. Actually, it's a modified Marchesam. So the first thing we do is ask our patient to tell us where is the tongue located right now. At rest, it should be located in contact with the palate just behind the incisor. If not, we should go to look for any myofunctional disorder. The other thing that we ask our patient, of course, we look at the tongue range motion of the tongue, elevation, protrusion, lateralization. But the other thing that we ask our patient is to open mouth widely. Then you can measure the distance between the incisors. And then we ask our patient to try to reach the palate with the tongue. Actually, patients with ankyloglossia cannot perform that maneuver. So they will start closing the mouth. Then we can measure again. And although they are 4 scale, we always say that with a difference that is more than 50%, we consider it a short lingual frenulum. Regarding myofunctional assessment, we always say that, well, we have the luck to be working with a speech therapist just in our hospital, so we rely too much on her. Actually, regarding the lingual frenulum, we never prescribe frenotomy. We always wait for the speech therapist, and she is the one that calls us and say this patient requires a frenotomy after working with the patient. So my recommendation is not to perform a frenotomy without any prior work from a speech therapist. About the myofunctional assessment, there are several protocols, but actually there's no standard. They all work on the coordination and strength, and they try to address key points like appearance, mobility, swallowing, lip seal, and of course the breathing patterns. One thing that we consider really important is to measure the strength of the tongue and the lips, and I will show you. First, why the tongue and the lips, and just those two? Because these two are really representatives of the orofacial muscles and are really easily to assess. How do we measure it? We are using this device called IOPI that is used mostly in patients with dysphagia. It presents this like a balloon, it's called bull. When pressure is applied to it, it gets transmitted to the connector to this device that will measure the pressure and give us in kilopascals. I say kilopascals because this is the measure that we use all around the world. It's validated. We measure the lips and the anterior tongue values. What we do is, first we explain to the patient, it's really easy, so you can explain just one time, a patient will understand it. We take one measure, give it our patient 1 minute to rest, take a second measure, 1 minute to rest, and then a third measure. And then we take them in and we consider it the peak pressure. That's our value. Why is it useful for us? Because first, it will help us to endotype our patients. if you remember about the 4 sleep apnea phenotypes, it helps us to identify patients with muscular hypotonia. It's really easy to perform, both in adults and also in children. Just as a note, we use it in children from 4 years old and more. And trust me, it's pretty reliable. We have normal values, also validated for adults and in children. If I recall, it was Potter in 2009 that validated the normal values in, I guess, 150 patients. And it helps us to improve adherence to myofunctional therapy. And how? Because we can give our patient a number, something objective that a patient can see, and it helps us to set therapeutic goals. Of course, we are not working with a number, but trust me, after 1 month or 3 months follow-up, patient comes to our office and he can see that after performing the exercises, the values of the OP increases persistently. And trust me, this is really helpful to increase the adherence of the patients. And accessible. Actually, it's not that accessible. The IOP cost around 3,000 US dollars or euros around the country, and actually it's not accessible. In Spain, for instance, only research groups are working with this, but it's not that spread as we would like to. But there are always some other options. My colleague, Dr. Laura Rodriguez, came with this idea of using a tongue digital spoon. This is the one that you can buy in a supermarket just to weigh your spices. And she worked and validated this device against IOP and provided with normal values. So the cost of this device is around $20, $30. So it's really accessible. A few years ago, this came into the market, the tongueometer. I haven't had the chance to use it or to try it because it's only commercially available in USA. Okay, and they not ship abroad. If you have the chance to test it, I would recommend it because the cost is only $400 or around, and it could be really useful. Nowadays, we are working with this device, trying to validate this generic manometer from Amazon. We are working with the original EOP ball and connector, and we don't have the definitive results yet, but by now they are pretty consistent against the IOP. The difference is that it costs maybe $80, $90. So what is our objective? Try to spread this practice all around Spain so everybody can use it. One detail about the EOP values and the correlation with the finding in the DICE, the drug-induced endoscopy. You know that we use this diagnostic procedure to identify the sites and different patterns of obstruction of the upper airway under sedation with propofol mostly, to identify and to predict which surgical procedure or which treatment could be helpful for our patients. A few years ago, they tried to correlate the values of the EOP with the findings of the obstruction at the level of the tongue in the DICE. And as you may see in this one, this is from the lips and this is from the tongue. There's a strong correlation between partial or complete obstruction of the tongue with lower levels of EOP values, both from the tongue and also labial. And of course, they recommend to use this instrument to assess patients with sleep apnea. So getting into the last part of our lecture, how is it that we can apply myofunctional therapy? And I know that there will be many myofunctional therapists attending this lecture, but the main thing, our colleagues published this a few years before, trying to sum up all the protocols. And the thing is, the protocols are so different that we still cannot recommend our patient about the frequency, duration, and type of exercises that could really benefit. All the groups are working in different type of exercises. Which difficulties do we find in our practice, at least here in Spain? First, access. There are myofunctional therapies in Spain, but actually it's not so easy to find. So that is the more important thing. And of course, health insurances do not include myofunctional therapy in the practice. The thing with access that we should take into consideration is not only the cost of the therapy itself, but also the cost in money and time that the patient has to use to go 1 or 2 days a week to a place that is not maybe 2 blocks from home, maybe has to take 20, 30 minutes to go to the office to perform myofunctional therapy follow-up. So we have to take this into consideration. One really important thing is that compliance to myofunctional therapy has impoverished between 10 and 25%, dependent on the authors. And of course, as I told you several times, there is no standardized protocol, so we cannot compare the benefit from one group to each other. This is this is from a book that is coming this year, but the important thing is to take a look. This is all protocols in children. As you may see, the length, the duration varies between 6 months, 2 months, 50 months, 1 week, 6 weeks. So there's no way that we can compare these therapies between each other. That is why we have to use telemedicine. We consider it really important. Actually, it has helped us all the way in medicine. And why is it useful? First, it can help us to reduce the economical cost, of course. It can help us to better provide a close monitoring of the therapy, and also it can help us to make little adjustment to the therapy of exercises of our patients. Of course, when working with children, it's really difficult sometimes to get the whole family in the office. When working at home with the exercises, is really so much easy to include everybody there in the treatment. And telemedicine also, this is really amazing while working with this. Until a few years ago, we were working always face-to-face. So I would refer my patient to the pulmonologist, and then after maybe 2 months, he will come back. And I say, oh, he said this. Then I will refer to the dental experts. And then we have spent a lot of time with our patient. With multidisciplinarity, we can integrate and add different colleagues on the evaluation and treatment of our patient, and it's really, really easy to do it. So I should declare a little bias with this app called Airway Gym because we are working with this every day and we are doing research with this app. It was designed by Dr. Carlos O'Connor, and we are using this every day with good results. Basically, what this app has is that the patient performs exercises just with the use of the smartphone. We have all the exercises, a set of exercises that are well explaining in text, but also every exercise has a video of our speech therapist explaining how to perform the exercises. After performing the round of exercises, it provides with a performance analysis, so the patient can analyze this performance, and through this chat, sometimes he can write to us telling, doctor, everything is okay, but exercise number 5, I'm always doing worse than all the others. So we can work on that exercise specifically, not having to wait until the next follow-up appointment in our office, maybe in 1 or 3 months, of course. What it provides is a really good feedback that is acoustical, that is visual and tactile. And it works by working the proprioceptive training, stereognosis, and praxia. One thing that I really like about this is as trainer, we can log in and address all the performance of our patients so we can identify whether it has performed better or worse the exercises. It has shown in a clinical trial that adherence went up to 90% with a 3-month period of treatment. That is way too different to the 10 to 25% that I showed you before. And this really helps us to enhance patient engagement. Because if you remind, everybody has a smartphone on the hand or maybe right there every day. In the long term, we are improving our outcomes. This is the clinical trial that I showed you before that I will get into detail right now, just to show you this. On this, they performed this, they collected 20 patients and divided into myofunctional therapy with the app for 3 months and control group without any therapy at all. The green is the control group and the blue one is the intervention group. This is a baseline, and after 3 months, we can see that EOP values increases significantly in the intervention group, but has almost no impact on the control, of course. This is patient by patient, the result on a sleep study, mostly in the apnea-hypopnea index, that it showed that several of the patients presented with a reduced AHI by the end of the 3-month period. So if you ask me, I'm using this app because I can see that works, but it also have clinical trials and they have shown me results that I can show to my patients and to other colleagues to recommend this app. So that is why I encourage you, if you are not working in a research group, try to get in contact with anybody that does research, because that is the only way to improve the prescription of myofunctional therapy. So a few words about passive myofunctional therapy, of course, that basically works in a different way. It doesn't require that the patient actively works with this, but we have, for instance, tongue retaining devices that keep the tongue in an anterior position, preventing from falling backwards. Also, orthotic devices that maintain the lips sealed and the mouth closed. This, I never thought of this until a few months before that a colleague told me that the hypoglossal nerve implantation is a kind of way of passive myofunctional therapy. With the repetitive electrical stimulation, it mimics the movement of the exercises that we actually perform with myofunctional therapy. Positional therapy may improve a better alignment of the head and neck, and also it prevents our patient from sleeping in a supine position. Then it will prevent the tongue from falling backwards. And the oral appliance that they will reposition the mandible and will stabilize the soft palate and the pharyngeal walls, tensioning and activation of the general muscles, of course, preventing the tongue collapse. And different studies have shown that in long term, there is a neuromuscular adaptation and coordination with the use of the mandibular advancement devices. Perspective. I would say that myofunctional therapy has an untapped potential because there are still not a standard recommendation in most adult sleep apnea guidelines. And I mean, all our colleagues that work sleep apnea, they really don't know about myofunctional therapy. They heard about it, but they cannot read too many things about this. This is what I told you about this review of official guidelines. Actually, there are two, the Spanish guideline and the European Respiratory Society, that consider myofunctional therapy as a treatment option for adult patients, but not as an isolated treatment option, but complementary to CPAP therapy. And as I told you, first, my question is, if sleep apnea is a breathing disorder, why is it that we do not address the signs of a breathing disorder? But who does? I told you there was one guideline that recommended it. Dentists. American Academy of Dental Medicine recommends the evaluation of tongue position and mobility and the length of the lingual frenulum. And that's all we have on official guidelines by this day. Sum up, we know that myofunctional therapy can improve subjective parameters of sleep apnea and also objective as snoring index, sleep apnea hypopnea index, and the saturation index. Of course, it will enhance stomatognatic functions such as breathing, swallowing, speech, etc., by providing a more stable upper airway. It helps us to achieve better compliance with the first-line treatment for sleep apnea, has also no adverse effects, and we should always consider, or mejor, take into consideration the role of telemedicine and try to add this to our practice. At last, if you are interested, I always recommend Dr. Carlos O'Connor Reina and Dr. Cristian Calvo Enrique from Spain. They are working with myofunctional therapy, and of course, Cristian Calvo is working too close with the dental expert. So if you get in touch with them, or if you have the opportunity to assist any lecture of them, trust me, you will enjoy them. So thank you for the attention. And I will start sharing the screen, okay?
Yes, thank you very much. That was great. I do have a couple of questions. I'm going to see if any others come in the chat, but you're working in a medical facility, is that correct? Okay, so you have the speech pathologists. Are you referring to them? Are they referring to you? What's the referral process like?
It goes both ways, but initially we assess the patient. So mostly we refer the patient to the speech therapist.
Okay.
But as we work closely, as I told you, we always trust in her opinion because she's the one that can tell us if the patient is going for surgery or not.
Right. Okay. Now, who's using the IOP? The ORLs or the speech therapists?
No, we as ENT, we are using the IOP.
You're using, okay. So do
Yes.
you get a baseline and then after they see the myofunctional therapist, you're assessing after? Because I know you're doing some data collection too, right?
No, yes, I will tell you first. IOP, you know that you could also use for the treatment of the fascia. We're not using that in our practice. What we do is measure the baseline, then we start with myofunctional therapy with the app.
Okay.
Our first appointment is after 30 days, 1 month, and then a second follow-up appointment in 3 months.
Okay. So the speech therapist is not always involved in that. Is that right?
If we consider that has a myofunctional disorder, we send our patient to the speech therapist.
Okay.
Exactly.
If it's just a sleep disorder, then you're using the app, right?
Exactly.
So how, and I don't have a lot of familiarity with the app. I've heard Dr. Carlos Reina speak too, and it was a great talk. How do you know which exercises to prescribe? Is it just a sequence of exercises or you program the ones you want the patient to complete?
Actually, as I told you, it's a set of exercises. It's not tailored. That's the main complaint we have with the app. Because we cannot tailor it like you could do it as a myofunctional therapist to tailor it. But as I told you, we really are scarce of myofunctional therapists here in Spain. So we are using this. But if we could work with one close to us, of course we work with them.
Okay. Can you tailor like the number of repetitions or the number of sets, or that's set?
It's all set, just one repetition from each exercises once a day.
Okay. This is going to sound like a silly question, but I remember my reaction and a lot of the reaction from other practitioners of myofunctional therapy in the I'm a speech pathologist. In the United States, we have primarily dental hygienists and speech language pathologists who are trained in myofunctional therapy. having the tongue on your phone, is that something? I guess I'm just thinking about like what contacts your phone. Is that something, how do you explain to them how to keep it clean and sterile?
Oh, don't worry about that because also here in Spain, I have heard my colleagues tell, but you are licking the phone. No, it's not like that. So many patients use like a plastic bag. So
Okay,
really, but actually you can use any screen cleaner that you may
okay,
buy to clean the. It's not that bad. Don't worry that the patient is always with the phone by hand also.
okay, got it, got
But
it.
understand the question. Yes, yes, I know.
Okay,
But
thank you.
actually, the first exercise is the one that I show you the picture with the speech therapist with the tongue in the mouth. So that is why it's more confusing to our colleagues. They
Okay, I
consider
know that's the one
silly
that they
because
always
that
show. Yeah, okay. Um, your work was so interesting to me because I'm working with a doctoral student at the university level, and her topic for her like a thesis, dissertation, capstone project is myofunctional therapy and obstructive sleep apnea. In the United States, speech pathologists are not allowed to use myofunctional therapy to treat sleep apnea for that reason. We don't have standardized protocols. And and it's something that I'm also aware of, and I think we need a lot more research to show that there's potential. Like you said, it's an untapped potential, and we're missing the boat with a lot of patients who have, the hypotonia of the tongue that can benefit from it. Um, are you familiar with the very recent work? This just came out like a month or two ago of Dr. Bianchini, Esther Bianchini. She did some research with endoscopy. So she's a speech pathologist in Brazil. They did some research with what particular exercises do show changes on like an endoscopic exam in terms of, do they open the lateral pharyngeal walls? Do they advance the tongue?
if I am talking about the same, give me 1 second, sorry.
Okay.
I
No, that's
showed this
okay.
to my colleagues just a few days ago. This is Alan. So, but I know what you're referring.
You know what I'm
The
talking about.
thing,
Okay.
yes,
That's, as far as
like
I know, that's,
myofunctional changes during oropharyngeal exercises for sleep disorder breathing. I guess you are talking
exactly.
about this from Da Silva. Okay,
Yes.
yes,
That's the most current, the closest that we
exactly.
have to something more specific. I mean, but we need a lot more evidence to.
Exactly. Actually, we can discuss about that because, but I would say it's a good effort. Okay. And of course, I think they can do really better, but it's a good effort. And I would like to see the difference within the baseline and maybe a 3 month period. If you read the article, it's mostly the endoscopy evaluation during the exercises.
Yeah,
Eh,
yeah,
But
exactly.
the thing is try to demonstrate that during the long term it will work. It's not that
Okay.
easy. I know it's not that easy because also it's not easy to design a clinical trial. It's not easy to get the approval of the ethical committee.
I
It's
know, I know.
really hard.
There's a
And
lot of red tape.
actually, if you don't have that much literature, and of course, if you don't have, let's say, an industry like hypoglossal nerve implantation back in Europe, it's get more difficult.
Okay.
Because to get funding for this kind of research is really a hard task.
Yes, I know. It's a big barrier, I think, and that's why we're sort of stuck where we are. Um, do you feel that 3 months is a decent interval, or do you think research needs to look further out, like 6 months?
In my opinion, they should continue. Okay. You told me as a speech language therapist, you know that patient with a laryngeal problem that say nodules in the, how you say, I don't find the name. Okay, you know the teacher when have we difficulties with the voice, you go for a speech therapy. and they improve, but after a few months, they forget about that and recur with the same problems.
Right, and they relapse. Yeah.
Relapse, sorry. So that is why, in my opinion, they should continue with the exercises because the patients really forget about this.
Okay. And the ones who are using the airway gym, let's say they make improvements. Is the recommendation to continue with that for a lifetime? Do they take a break?
Sleep apnea is a lifetime disease. That is the main thing. And we are working with a patient that something led to that patient to this hypotonic endotype. So probably you will not change that in 3 months, 6 months, or even in 2 years therapy. So my recommendation is to continue with the therapy.
Okay. And I have one last question. This one is about, and you mentioned this earlier, this was my favorite slide from your presentation when you were breaking down all the benefits of myofunctional therapy, mobility, endurance, strength. And you mentioned stereognosis and praxia. It's very interesting because stereognosis is not, at least in the States, is not something that we do a lot of. So I just wonder how that's incorporated, I guess, and what you mean by stereognosis, if you could just explain that a little more.
Have you heard a patient that tells you, I have something in my gum, but it's on the right side? How is it that he identified that? By touching with the tongue. Okay, and how we can work it? I cannot have it here. Dr. Correa has a publication working with different figures like circles and rounds, etc.
Yeah,
Working in different shapes with a blindfold, asking the patient to identify the structures. And actually, after myofunctional therapy, there's an improvement of the recognition of the different structures.
Okay. And that's part of airway gym too?
Actually, yes, because it has this tactile feedback.
Ah, okay. I understand now. Got it. Okay.
But it's the same as they say you're a myofunctional therapist, and you say, okay, one exercise is to, I don't know, lift and go down with the tongue. It seems easy, but has a lot of fundamentals backing up.
Yeah.
You're working with the recruitment, with the sensorimotor recruitment. It's not just moving the tongue.
Right, exactly. Or even being able to distinguish different tastes, putting something in their mouth. What do you feel? Okay. Thank you. I've enjoyed it very much. I hope everyone else did as well. Thank you very much for everything you've been able to share. And if there is any research, please let us know what to keep an eye out for if you're working on anything, because we'd be happy to see what you're coming out with. I just wanted to mention for anyone who has been watching our TNLs, thank you for your loyalty. And I hope that you will keep an eye out for our newsletters, and our weekend newsletters have important announcements about upcoming speakers, guest speakers, and we hope you'll continue to join us. So thank you very much once again. And hopefully we'll be able to have you back at another point in time.
Thank you for having me.
Okay, you're welcome. My pleasure. Have a good
Bye
weekend.
to everybody.
Okay, thank you. Bye-bye.